The Exploring Ethics Forum, it was envisioned as an opportunity to bring together experts in the field, as well as folks who are impacted by the decisions that experts and policymakers make, to bring together to address and to talk about some of those pressing issues. And so I want to thank you all for coming out and being a part of that. Our speaker today, many of you have had an opportunity to meet her already, is Dr. Ingrid Holm, who is the chair of the IRB at Boston Children's, as well as the endowed chair in genetics and genomics at Boston Children's.
All right. It really is a pleasure to be here. And so what I'm going to talk about today is about genomic sequencing and newborn screening. And I'm going to start off just talking a little bit about what newborn screening is, talk about incorporating genomics in newborn screening. Then I'm going to talk about a project that we're doing called BabySeq, and then we'll get into kind of what some of the ethical and public health issues are with incorporating genomic sequence into newborn screening. All right, so what is newborn screening? So newborn screening is a worldwide public health program. So it truly is a worldwide program. The purpose of the newborn screening is to detect potentially fatal or disabling conditions as early as possible before there are signs and symptoms. And this leads our ability to then treat immediately to reduce the effects of the condition and prevent devastating outcomes. So it's all good and it's all very important. And it's been really a huge success. So it started in 1961 with a metabolic disease called phenylketonuria, or PKU. And since then, it's really expanded significantly when something called tandem mass spectrometry, or MS came along and gave us the ability to test a bunch of conditions at the same time using a kind of a biochemical test of spectrometry. Most states report over 99.9% participation. And if you think about it, there are about 4 million infants that are born a year in the United States. Over 12,000 newborns a year are diagnosed with one of the core conditions on newborn screening, which means 1 out of every 300 newborns screened. So it's really made a huge difference. So the way that newborn screening works is there's something called the Recommended Uniform Screening Panel, or otherwise known as RUSP. And on the RUSP, it's just a picture which on it, but to kind of summarize, there are 35 rare conditions, including metabolic conditions like PKU, endocrine conditions like congenital hypothyroidism, some hematologic disorders like sickle cell anemia, and then others which include non-blood tests, so a hearing test and a testing of a pulse oximetry for congenital heart disease. In addition, there's another 26 kind of optional kind of secondary conditions that are on the RUSP. Newborn screening is regulated state by state. So what happens is that each state decides what they're going to put on their newborn screening panel. On the other hand, we have these 35 conditions. There are over 7,000 rare, mostly genetic conditions that we know of at this time. About 80% of them are genetic, and about 10% of individuals worldwide are affected by a rare disease. So rare diseases are rare. Having a rare disease is actually not rare. So when we think about all these people who have one of these rare diseases, there's something called the diagnostic odyssey, which is really what up to now has been a 5 to 6 on average year journey that patients with rare diseases take to get to a diagnosis. And it really does kind of look like this. It means meeting other doctors, having tests done, having imaging done, going kind of from physician to physician to try to make a diagnosis. And so that's what we call the diagnostic odyssey. So of those 7,000 rare conditions, over 800 at this point are actually treatable. So this includes specific medications, stem cell or organ transplant, medical procedures, supplements or special diet, specialized proteins, and importantly, gene therapy. So there's currently only about 4 conditions now that are approved for gene therapy, but as time goes on, this is definitely going to increase as there's many more that are in development. So we have 800 or so, over 800 treatable conditions, and the RUSP only detects 35 of them. In addition, it takes 9 years to get one condition on the RUSP. And this, on this here on the right, is not meant to read in detail, but just to give an idea of how many steps there are in that process. And a lot of these are like committee meetings and bringing evidence and all this stuff together. So it's a very arduous process to get one condition on the RESP. All right, so then if you think, well, what if genomic sequencing were incorporated into newborn screening? And just to remind you that in, for example, in the NICU, so the neonatal intensive care units, we are currently using, some places are using rapid genome sequencing to make diagnoses. And these are just some examples, some things that have come out, including from Rady Children's Institute for Genomic Medicine, where the genomic sequence is really being used much more and more clinically to make diagnoses and to kind of end this diagnostic odyssey that a lot of patients and families go through. So if we were to take that kind of genomic sequencing that's used, say, in the NICU and have that be part of newborn screening, the consequence, what we would able to do then is, first of all, test for 1,000 conditions at the same time. So in a sense, taking that mass spectrometry and multiplying it by kind of magnitudes to test a whole bunch of things at once, which would allow for interventions early in childhood in children with diseases that are rare, treatable, and preventable. And potentially, even those that don't have a treatable disease, we could potentially eliminate that diagnostic odyssey that a lot of parents go through. And finally, as soon as a genetic condition made whatever criteria we had to be on the newborn screening panel, that could be added the next day, because it's just a matter of adding one more condition that's already been sequenced on the sequencing that's being done. So this kind of this whole idea, I think, kind of led to this quote, which is kind of the favorite quote of anybody who does research in this area. Whether you like it or not, a complete sequencing of newborns is not far away. And this is Francis Collins, who was the former head of the NIH and the NHGRI, the National Human Genome Research Institute. And he said this in 2012. So it's been 10 years almost, and it's not happened yet. Well, it's over 10 years, hasn't happened yet. But anyway, so that's kind of where we're going with this. So what has kind of led us to think that you could potentially incorporate sequencing into newborn screening? And one of those factors is that the cost of sequencing has plummeted. And so this is another one of these favorite slides of geneticists, where you look at what it cost in in the year 2000 to do a genome, which was like $100 million or whatever. It was like, just to do the Human Genome Project was like billions of dollars for 1 or 2 genomes. And now we're down to, at least here, this is in 2021, less than $1,000. And now soon there may be sequencing available for several $100s to just do one sequence. And a lot of this kind of decrease in cost and ability to do sequencing at a good cost has partly driven this real interest in genomic sequencing and using it for diagnosis and potentially for screening. However, genomic sequencing generates a mountain of data. So if you do exome sequencing, there's 4 million base pairs in an exome. So the exome is the coding part of your genome that codes for all the proteins. It's a very small amount of the genome, but the important part. So 4 million base pairs and 35,000 variants. And genomic sequencing, if you do the whole genome, you have 3 billion base pairs and over 3 million variants or changes in the DNA. And the reality is that much of it that we don't really understand very well. So what we don't understand about the genome is, first of all, the genes. So only some of the genes are known and are known to cause diseases, but a lot of them, we don't really know what they do. We don't really understand always what the impact of changes in genes, so those are what we call variants, so what those impact of those changes are on gene function. We tend to focus on changes that we think are likely pathogenic and pathogenic, which means that we think really do change gene function, but a lot of them we don't know. We don't know the clinical implications of variants in many genes. In many genes. But anyway, so then the question is, why does this matter? And it's because there are ethical implications to returning certain information to individuals. And I think that that's something that, as we go through this, we really have to think about. There's a lot that's not known about the genome, and how do we kind of figure that into what we're thinking in terms of incorporating genome sequencing and some of the ethical implications. Okay, so that was kind of a background. There are now a number of studies that are being done to look at this idea of adding genomic sequencing to newborn screening, including the one that's in the top middle there, the beginning study, which is at Rady Children's here in San Diego. Another one, just to point out, is Genomes England. So in the UK, there's a big project to do 100,000 babies in terms of doing sequencing in the newborn period. And what I'm going to talk about is our project, which is called BabySeq. So the BabySeq project was, it went from about 2015 to 2019. It was a randomized controlled trial, so an RCT, of genomic sequencing in healthy and sick infants. And the reason we did this, and it's actually, I think we're probably one of the only studies, at least that I know about, that has done this in a trial, is that this gives us kind of this unique ability to compare those who enrolled in the study and got sequencing done and those who didn't get sequencing done. So it's a little bit more of a rigorous way of looking at the impact using this randomized controlled trial study design. So the idea is was to explore the impact of incorporating genomic sequencing into newborn screening. So we looked at the medical impact on the individual and on public health, the behavioral impact on physicians and patient behavior, and the economic impact in terms of the cost of healthcare. So when this project started in 2015, there was a lot of concern that we were going to be doing psychological harm to families by giving them information on their baby in terms of genomic sequencing and risks for disease early on. It was really, that was kind of one of the main issues, and this study was it was designed to really try to look at that. So as I said, it was a randomized controlled trial, and so we had two cohorts. We had babies who were in the ICU, so most of them were in the NICU, and there were some in the cardiac ICU at Children's and the Brigham and Women's Hospital, and then we had a healthy new cohort of well babies at the Brigham and Women's Hospital. And within those two cohorts, we randomized them to either kind of standard of care plus we did kind of extensive family history, or the same plus doing genomic sequencing and returning a report. We disclosed the results, the families then came back, we disclosed the results to them, we sent the results to the pediatricians and our neonatologists who were caring for the baby, and then put them into the medical record, and then looked at all these outcomes that I just talked about. And so what did we return to families? So we returned this newborn genomic sequencing report, which had risk for childhood onset and two highly actionable adult onset conditions, but primarily risk for childhood onset conditions. They weren't necessarily treatable. So we kind of looked at everything that was a childhood onset, so that included conditions that a child may have or be at risk at that would not be treatable. So a lot of kind of the developmental disorders that we can't do anything about, those were also returned. We returned carrier status for childhood onset disease, and then we returned some what are called pharmacogenomics, which are changes in the genome that affect how you metabolize medications. And then, and so that's basically what returned. And so this ended up being about 1,000 genes that we analyzed, and we looked at how valid the relationship was between the gene and the disease, the penetrance. We tried to get things that we thought were fairly likely to cause a disease, and age of onset. So these are some of the criteria that we used. But it was about 1,000 genes in total that we returned. And this does set BabySeq apart from the other sequencing studies that I talked about earlier that really just are looking at actionable disorders and things that can be treated kind of early on in childhood. We just had this very wide aperture. And so what were our findings? So we ended up enrolling about 350 babies, and 159 were sequenced. And basically, in 11% of them, we found one of these disease risk findings. And just in summary, there were 4 babies that had a finding and had evidence for the condition, and actually one of them was also detected by traditional newborn screening called biotinidase deficiency. So there are 4 babies that kind of fit into that. And then there were 7 babies who had a pathogenic variant for a condition that they didn't have evidence of, but there has a family history of it. And these were mostly kind of cardiac things, so not like, so more like cardiomyopathies, that type of thing. And so the baby didn't have it, but there was a family history. And then, of note, regarding this issue of penetrance and how well we know that the gene finding actually caused the problem we think it's going to cause, there were 5 babies who didn't have evidence of the condition that we found, and they didn't have a family history of it. So even though we use this idea of penetrance, you know, this, that the gene, changes in the gene will cause a disease, we use that as a criteria. It gets to the point that we don't know the penetrance truly of a lot of diseases, and gets to that kind of uncertainty I talked about earlier about the genomic information. And then we did a whole bunch of surveys. So we did surveys at baseline, right after returning the results, 3 months later, and then like 10 months later. And we looked at parental depression, anxiety, self-blame, and parents' perception of the child and their relationship. And the way all of these charts work is that the control group who didn't get sequencing are in green. The group that got sequencing but didn't have any findings are in blue, and the ones who got sequencing and had one of those findings I just showed you are in orange. And then at the top there, in the 3 at least, shows what the cutoff is for being of concern. And so the bottom line is that all of these groups were way below the cutoff, and there really wasn't a difference between the groups. So there's really no evidence that there was any impact on these kind of 4 categories in terms of the parents' kind of response to getting this information back. So kind of in summary, this BabySeq project was the first comprehensive sequencing of healthy newborns. 11% had a finding, and there was no evidence this information upset the parents. In addition, which I'm not showing you, but we also didn't find that it substantially increased healthcare costs. However, almost all the parents enrolled were non-Hispanic white. And so the Brigham and Women's Hospital is a very diverse newborn nursery. It's in a children's hospital, right next to Children's Hospital in this area, Boston. It's right next to a more kind of inner city area. It has a very diverse population. Our NICU has a very diverse population. But the people who signed up for this study were essentially, as I said, white and non-Hispanic. And so this has led us to the second project that we're in right now, called BabySeq 2. And so it's implementing whole genome sequencing as opposed to exome sequencing as a screening in a diverse cohort of healthy infants. So what we're trying to do in this project is to address this lack of diversity. And so the issue is that there's a lot of distrust of research in genetics about underrepresented minority populations for very good reasons. They have a lot of reasons why there is very little trust. And so we also know that if we're going to think about incorporating genomic sequencing in newborn screening in an ethical and just manner, it's crucial that individuals from a broad range of ethnic and racial backgrounds are engaged in the research that will inform how it can be integrated into newborn screening. So in other words, we need to include everybody if we're going to really think about putting this forward as a public health program. So this is just a BabySeq project. We have a bunch of sites, and this is just to kind of show that it's a little bit of a nationwide, though mostly on the east side. And we're really focused on enrolling diverse participants. And the way that we're doing that is that we're not enrolling right after birth. So, I mean, first of all, it's hard to enroll when someone just had a baby anyway. For anybody who's had a baby, it's not like you're thinking about research when you're in the hospital and just had a baby and you're going to go home in 2 days. So we're actually, instead of doing that, we're going to community health centers that serve underrepresented minority populations and enrolling babies in the first 6 months of life, recognizing that newborn screening is done right after birth, but at least this is still when babies are very young. So I think will give us still some information that about how to incorporate into newborn screening. And so we're enrolling at Boston Children's Hospital in this the Children's Hospital Primary Care Clinic, which is kind of an inner city clinic, primarily African American, Hispanic patients. Mount Sinai in New York at the Mount Sinai Pediatric Associate Practice, which again is primarily African American and Hispanic, and then the University of Alabama's Children's Alabama Primary Care Clinic, which is a clinic that serves primarily African American families. So that's it, kind of a background of what we're doing and what we're kind of thinking about when it comes to thinking about enrolling patients or doing studies and trying to see what it would be like to get genomic sequencing into newborn screening. And so now what I want to turn to is, I think, kind of what you're kind of interested in are kind of some of the ethical issues and the public health issues if we're going to actually do a program like this as a public health program. So my first question is, for those of you who have children, do you remember when your child had their newborn screening test? So I don't know how many people have children here, but I have twins. I do not remember when they had the test. I don't even remember them coming back with a Band-Aid. I spent 4 days in the hospital because I'd had a C-section, but I do not remember. And the next question is, did anybody ask you? So even if you remember, did anybody ask you if you're going to go through the newborn screening? And I guess most people would probably say no. And so this gets to where we are with current newborn screening and kind of consent. So newborn screening is mandatory without parental consent in most states. And there's this debate versus a privacy and parental autonomy versus positive benefits of newborn screening. And these blood spots are also retained with identifiers as per kind of the state laws. And there's again debate about collecting samples without parental consent and storing them for research. The reason, so theoretically people are supposed to hear about newborn screening, I think, kind of before they have a baby, like in the obstetrician's office, which really doesn't happen very much. And the fact that there really isn't consent, that oftentimes parents don't really know about it, is not really seen as a problem from the newborn screening public health perspective, because no one wants anybody to say no. Because these are looking for diseases that are so treatable, to bring such devastating outcome, to have a child who's essentially normal versus a child who's completely devastated, that they're really, if you ask, they might say no. And so that's part of why there hasn't been a big push for kind of consenting in the newborn screening, because it's felt to be such a vital public health program. And that's why 99.9% of people have newborn screening, is because nobody asks. We just kind of do it. So if genomic sequencing is incorporated into newborn screening, what are the things, some of the things that we have to kind of consider from an ethical and a public health perspective if we're going to do this? So this gets to, is one of the issues, which is privacy in genomic data. So just as a reminder, everybody's DNA sequence is unique. That's why we're all different. And because it's unique, it can't be truly made anonymous. Now, if you hand me somebody's sequence and I look at it, you know, it's ATGC, I can't say, oh, that belongs to so-and-so. You can't look at it and it's self-identified. But if you have another sample and you have this sample, you can identify, and that's how a lot of kind of in forensics is done. So it's not truly anonymized. And it's been shown that DFI genomic data and other data can be re-identified using other database sources, such as genealogical databases, Ancestry.com, 23andMe, who have kind of genomic data. And there's also been recently some of these cases, and this is an example, of using dried blood spots in criminal cases. And so this is in 2021, a man was convicted of sexually molesting a 10-year-old girl in 1996, after the New Jersey police analyzed the DNA of his child who was born in 2012 by going to the newborn blood spots. So there isn't really true privacy in terms of with genomic data. It is identifiable. And finally, this is, the government has my DNA. So this was a kind of in Texas a few years ago. There was people who kind of, I think, kind of sued or did something, whatever, to the Texas government because of the legislature, because they saved the blood spots. And so they didn't have the baby's DNA. They had the blood spot, but you can derive DNA from it. And so now Texas, my understanding is that they don't save the blood spots after a certain amount of time. They get rid of it. And for people who kind of do research in this area and trying to, with the blood spots, it's really a little bit of a travesty that we have to get rid of all these, because there's a lot of things, that can be done in terms of research-wise with blood spots, but they are now have to get rid of them. All right, so that's privacy and data sharing. The other is what results to return to parents. So just remember, the baby has no say in this, right? So the parents are proxy in decision-making for the baby. So it's not like we're going to ask the baby what results they want in themselves. We're asking the parents. So this gets to this kind of spectrum of genetic results. And so we've kind of, we think about genetic results in terms of what can be done about them and what is the age of onset. So we start off with, think about newborn screening, childhood onset, treatable, preventable conditions. It certainly would be something that we would want to return to a family because we could do something about it. That's the whole point. Then there's these childhood onset conditions that are not treatable or preventable. An example I give is something called Rett syndrome, which is just a progressive, devastating neurologic condition that at this point at least is not treatable. Now, gene therapy in 10 years, maybe it will be, but right now it's not treatable. Then there are adult onset conditions that are treatable or preventable in childhood. So that means that there is something you can do in the condition tends to happen in adults, but it's known to happen in children. You might do some screening in children. So there are, for example, some cancers where there's screening that will start maybe late in childhood to kind of look for that condition. Then there's carrier status, which means that you are carrying one of your genes for a condition has a variant that makes it non-functioning, but the other one is fine, so you're not going to get the condition, and that's also kind of part of the spectrum. Then there are conditions that are adult onset and treatable only in adulthood, so there's nothing to do in childhood. And so the classic example are the BRCA-related hereditary breast and ovarian cancers, the Angelina Jolie kind of thing. And so those are really, there's nothing to do in childhood to treat or prevent them. And then there are conditions that happen in adulthood that are not treatable or preventable, which is something no one would return certainly to a baby, things like Huntington's disease and that type of thing. So in the BabySeq project, we returned most of these. We returned 2 adult onset conditions. We returned the BRCA and Lynch syndrome, but the rest of them we didn't return. But that was a kind of a spectrum that we were looking at returning. And most other studies that are being done in this area are really just returning a childhood onset treatable and preventable conditions. So if you think about what to return, just maybe kind of stop and think about what are the kind of ethical principles. And I think the 2 important principles, one is this best interest principle. So it's clinicians have a duty to act in the best interest of the child, and parents have a central role in also acting in the best interest of their child. And then there's this ethical principle of autonomy, where it gets a little bit more kind of interesting, which is there's parental autonomy, so parents have the right to make decisions about themselves and their child. But there's this whole concept of the child's future autonomy, so it's this right to provide the child ability to make future self-determinations. So by not making decisions for them early in childhood that they maybe didn't want you to make, is leaving that open for them to make some of their own decisions later on. So those are I think, kind of the 2 ethical principles that come into play as we start to think about what results to return. The other kind of thing to think about to make it even more complicated is the impact of genetic information on families. And so the issue is that if you identify a child at risk, it may be that their parent is also at risk. So these are conditions that are autosomal dominant, that are passed down in a family. And so if you identify a child that has an autosomal dominant condition, there's a very good chance that one of the parents has it, and it may be that they don't know that they're carrying it and they are at risk. And so then this gets into this kind of concept of what are the best interests of the child. So if you have a kind of adult onset condition that's not going to affect the child until they're later in life, but the parent might have, is it in the best interest of the child to not tell them about it, to preserve their future autonomy to decide if they want that information? Or is it in the best interest of the child of having parents who are alive and well, because you've now told them that their parent is also at risk for the same thing, and now maybe there's something they can do, and so now you're kind of, in a sense, saving the family. And so it's this concept of not just best interest of the child, but the family interests, and that medical management of the family is often in the best interest of the child. And so this is another thing that kind of a thorn to put in there as you start to think about what kind of results to return to families in the context of doing newborn screening. So what are we going to share with the families? Are we only going to then share actionable results, like a lot of studies are doing? What about the value of making and reducing the diagnostic odyssey? What about personal utility in terms of what the parents want? Are we going to return childhood onset only conditions? And then we say, well, what about the family interests? Are we preventing, potentially saving a family or members of a family from a condition that they didn't know they were at risk of? What about carrier status? Again, we're returning all of these in baby-seq, but it's something to think about. Carrier status, that actually doesn't help the child at all. It may not help them when they're going to go on to have children down the line, but it doesn't affect their medical care. But it may help the parents with reproductive planning. So if they know that the child's a carrier, they know that they're a carrier. And as it turns out, it's possible they may both be carriers and they just didn't both pass on a condition. And then there's this whole role of personal utility to families. What is important to families? What do they want to learn about? How do they make decisions, make kind of their own decisions? And then what are the potential psychological risks of genomic sequencing in newborn? And so there are still kind of this risk of psychological distress due to unexpected disease risk. You know, parents aren't expecting to find something and then you tell them that they have a risk for something. We also, for some of these, if you do sequencing, we don't know maybe when it's going to happen or if it's going to happen, but we know they're at risk, and is that going to create this psychological distress? There's going to be uncertainty about anxiety due to certainty to findings. We don't actually return variants of uncertain significance. We really only turn in screening variants that are pathologic, but there's still issues, again, of this penetrance and expressivity, and so there's a lot of uncertainty. There may be negative impacts on relationships between the family and the family for this kind of information, or stigmatization and discrimination. So there really are some kind of potential risks. There's also, I should say, that there's a risk of additional unnecessary testing. So this is more of a kind of public health, health economics risk. So as I said, in the baby-seq project, we didn't find evidence of any of these potential risks, but there's really a lot more work that needs to be done in this area. You know, baby-seq was a very, again, kind of a specific population that we're trying to kind of expand upon. But I think that even though there's no evidence now that there's really severe psychological harm, I would argue we probably don't fully know what the potential psychological risks are. And what about consent? This is a real, I think, kind of problem. Are we going to make it mandatory? Are we going to do what's done now and just sequence your baby's genome and not really ask you about it? Is it going to be optional? Are we going to say that, you know, we're doing the regular newborn screening, the option of having this other stuff done? Are we going to have kind of an opt-in where people have to say, yes, I want to do it? Or is it going to be more of an opt-out, which is now we do it on everybody, but people can say no? In some states you actually can't say no. What results are we going to return? So after all this kind of stuff I've gone through, how are we going to make decisions about what to return and what the families to receive? What about pre-screen counseling? I mean, there really isn't pre-screen counseling now in newborn screening. No one really talks to families about it. Maybe we just do it. And so what's going to happen with that if we're going to add genomic sequencing? What about education, not just for pregnant people, but for largely education? I mean, if we're going to do something and really dramatically change a public health program, the public probably needs to know about it. What are we going to do about storage of genomic data? You know, this whole identifiability, privacy, using that information, that's a huge issue kind of going forward, is what are you going to do with all of that data? And are you going to allow genomic data to be used for research? So it's very powerful to have all this genomic data and so many research opportunities, but is that something that we're going to kind of allow to do? So I just should say that there's a little bit about parent perspective. So we've done interviews and surveys of this diverse community that we're enrolling prior to starting Baby Seek 2, and others have done similar kind of interviews in both diverse, some in diverse communities. And just to kind of give you an idea of what kind of families say. The families we talked a lot about the value of early diagnosis and treatment for their children. They talked about potentially the appropriate surveillance for adult onset conditions as their child age, so getting these back and their ability to then to look for them as time goes on. A lot of them talked about this kind of personal utility, and many people were in favor of screening for conditions where there was no treatment, because at least they would have an answer, they would be able to accept it, and all of these kinds of things. There was also, we found, strong support for requiring informed consent for genomic sequencing in newborn screening, more so than the current newborn screening. So there was support, kind of mixed support for maybe we should be getting consent for current newborn screening, but there was really almost unanimous support that if we're going to do genomic sequencing, we really do need to get consent. And again, these are kind of the things that families are telling us, and these are just some of the references. And then there's a public health perspective. So a lot of what I've talked about is a little bit more of like the individual perspective, but what about the public health? So first of all, genomic sequencing can't fully replace newborn screening because there are things on there that are not genetic. The classic is congenital hypothyroidism. It's just not genetic. And so you have to do a biochemical test for it. And there's some conditions that we don't use blood for. So again, hearing screening and that type of thing. So, and then there's also the fact that for some conditions, the biochemical test is still more accurate than the genetic test because we don't understand the whole kind of genetic landscape of the gene. So it's really, and in fact, one of the projects that was part of the initial BBC project at UC San Francisco did a study where they looked at sequencing for metabolic diseases and then looked for the biochemical testing in children in California who had metabolic diseases, and the genetic testing wasn't as good as the biochemical test. So there's several reasons why we can't currently at least replace genomic sequencing from the biochemical testing. The other issue is that programs are state and not federal programs. So currently, what state you live in will determine to some degree what you get on your newborn screening. So most states do the 35 on the RUSP, but that other 26, there's more of a variety. So state by state, there are differences. So what are we going to do? We're going to have states where you have your genome sequenced and the states where you get the 35 conditions on the RUSP. I mean, you could create large differences between states and what information people are getting back because of the way this is set up now. In our current political climate, it's unlikely to change. I mean, there's a lot of emphasis on states' rights, but it's a real problem, I think, for newborn screening. And I should also say, this is why Genomes England can enroll 10,000 or 100,000 babies in a newborn sequencing project, because they have national health insurance and they have one system. So they don't have to worry about differences, in kind of state-by-state differences. Infrastructure, how are we going to set the infrastructure? How are we possibly going to implement it, and who's going to govern this? And people are not going to trust a system if there's really not a clear kind of governance over it. Again, data storage and public and privacy. Where is the data going to be stored? I mean, currently large biobanks store data in the cloud, but how are you going to do that? How are you going to protect it? How are you going to make the public feel confident that it's not going to be used in some nefarious way? The government is doing something with your DNA. Education. And so I would say that, there's again, education again of parents who are, people who are pregnant and in that area, but has to be a lot of education of not just parents, but providers. A lot of providers don't really know much about genetics, about policymakers, and the public. And again, we're kind of in this era where there's so much distrust of science that it's a little bit more of an uphill battle than it would have been, it was before, but it's still a big issue from kind of the public health perspective. Then this is what we're going to do with the healthcare system, right? We don't have national health insurance. We have individual insurance, and even things like Medicare or Medicaid and kind of Obamacare do not apply to all states, not all states have adopted kind of a safety net program. And so what are we going to do to the healthcare system where now there's all these children that are being identified early on as having an issue, and what if they don't have insurance or they don't have adequate insurance? You're telling people they have something and then they can't do much about it. The insurance issues, I mean, there's all these issues with our kind of our healthcare system. And then there's this issue of health disparities and health equity, which really kind of comes out of that. Are we going to tell people they have something with them, they don't have an ability to kind of do anything about it? Are we going to exacerbate the health disparities and the issues with health equity that already exist by adding this kind of sequencing into newborn screening? So then the elephant in the room is, is this really feasible? I mean, you have to take this process, which is just the idea is that there's a whole bunch of steps that go into from the time you get the DNA until it comes out with the kind of analysis, and this will have to be automated. Now with AI, it probably can be automated, I'm sure it can, but getting this done on a large scale and automated is kind of one of the feasibility issues. And then there's a cost issue that even if it's $200 per baby, that's really expensive for a public health program. I mean, there's 4 million babies born in the United States, and if you do the math, that is a lot of money. And so what are we going to do about the cost? Will the cost ever come down? And it may be that in 10 years the cost will come down, but I think right now we're not at that point. And then there's the timing. So currently, if you get these, as I showed earlier, these rapid clinical exomes, like in the NICU, it takes about a week to get a result back, which is pretty fast. But that's still probably not fast enough in terms of when you get an actual result. It takes longer, and it's much more expensive to do a rapid exome than to do one that kind of regular. I just put this in there because I think it's kind of funny. This is Ewan Ashley, who's at Stanford, and he has the Guinness World Record for sequencing a genome in about 5 hours. And so if we can get to the point where we can do this in 5 hours with all the other stuff going on, it might actually kind of be feasible. So kind of in conclusion, this is kind of where we are now. This is from Robert Green, who's my kind of co-PI on the BabySeq project, where in terms of your prior probability of getting sequence done, if you're in the NICU, there's a good chance you problems you'll get it done. If you have an obvious finding, you're going to likely get it done. Maybe you have a subtle phenotype or biomarker, maybe cascade testing family history, but it's really just at the top end where people are getting sequencing done. And the idea is to flip that around so all babies get sequencing done, and then we can look at what's the family history and the implications and do cascade testing, look for biomarker, look for subtle and kind of obvious findings. So I think that, incorporating genomic sequencing in newborn screening really has a huge potential, but there's so many questions left that need to be answered and addressed if we're ever going to get there. And I do think we will. I think we will eventually get there, but we'll have to see. So this is just kind of in conclusion. These are all the people in the first BabySeq project, and then this is our kind of leadership team for the second BabySeq project in Boston, New York, Birmingham, Alabama, at the Broad Institute, and at Baylor, and then the whole kind of BabySeq team with our funding. And a special thanks to a lot of community members who helped us develop this project, providers and the families who have participated. And thank you for your attention. I'm happy to, do our panel.
All right. I want to thank you all for joining us. Whether it's whole genome or whether it's exome, that parents can have maybe access to with a private lab is going to drive some of the early testing that families want, even if it's not covered by insurance or done in a hospital.
That's an interesting question. I'll talk about that for a second and hand it on. But in my classes and my students, we often talk about 23andMe and just the general direct-to-consumer genomics, where you send your sample to a company, it directs to the company, it comes directly back to you with no intervention by a clinician or a genetic counselor or a psychologist to help you interpret that data. And when you mentioned, Ingrid, in your talk about having counselors help interpret, I think that would be key, because the DTC, direct-to-consumer companies, don't have that. You can take your results to a clinician, but not all clinicians are trained on how to interpret those results either. In fact, most clinicians don't know, especially about uncertain results, and the results are always changing. Interpretation of results is always changing as we learn more information. So I'm very cautious about direct-to-consumer genomics filling in that gap, but I also think it's going to be phased out if this newborn screening takes over, because 23andMe, I've read quotes that they think they will be made, they'll go out of business soon if the mandatory newborn screening happens. So it may be a moot point whether or not we think DTC is useful, because they may not be around long enough. If every baby gets a full genome screening at birth anyway, it won't matter anymore. But I do think having the clinician intervention and the genetic counselor or psychologist to interpret those findings is important, and that's why it's concerning if people turn to DTC instead of going to a clinician.
So I think that's a really fascinating question, George. The idea that a company could potentially do what Dr. Holm has been proposing, which is to offer to sequence your newborn child, potentially also do sequencing on your eggs or your sperm before you even have your child, right? And there are a lot of DTC companies, I think, that are looking to jump into this space of trying to offer that service directly to consumers. There are advocates of that who say that it sort of democratizes access to some of these technologies because it makes it available directly to the consumer. But there are also a lot of critiques of, some of the things that Dr. Knott brought up, which is, a lot of times these commercial tests are not very highly validated, so the kinds of results that they return are not research vetted, they're not backed up by evidence in the published literature, they're not endorsed by scientific and professional organizations. So some of those results can be potentially misleading, false, inaccurate. There's lots of issues, especially with 23andMe's ancestry testing service in terms of the concordance with other companies. So if you take your DNA and give it to 23andMe and Ancestry.com, it's possible that you'll get discordant results that say you have ancestry from one place or one set of places in Ancestry.com versus a different set of places with 23andMe. And there are published studies to illustrate that concordance is actually, I think the highest level that's been reported is about 86%. So there are some of these issues of accuracy that emerge in that DTC space that would possibly give consumers pause. On the other hand, there's also issues of equity and access. So a private company is at liberty to price their products at whatever range they feel a consumer is going to be willing to pay. And there are ways in which private companies could take advantage of potentially more well-resourced or well-advantaged prospective parents and parents who are able to pay higher amounts to get their own sequence determined of their gametes, or to have potentially their embryos sequenced, to have their newborn sequenced. All of that kind of creates these kind of disparities and kind of exacerbates some of the disparities that Dr. Holm brought up in terms of being able to access those technologies, because if only a certain slice of our society is able to access them, then those kinds of benefits are going to disproportionately be distributed to those advantaged groups in our society. So there's lots of really interesting questions to think about in that direct-to-consumer space, and I think a lot of us in the public health space are really kind of cautious and sort of skeptical of the ability of the private sector to kind of step in and offer this as a service that's going to be done in a responsible and ethical way and in alignment with the values of communities.
Yeah, and so just to say that also this whole issue of the direct-to-consumer in a sense drives the research. Because if we don't do empirical research that's robust and well-designed, it just gets out there with the direct-to-consumer companies kind of doing this, and people doing this without having all the considerations that go into, kind of our randomized trial or the stuff that's being done at Rady Children's and elsewhere. So to me, we used to say when we started doing this project is that if we don't do it, we need to do this right, because otherwise someone's going to do it, and they are in the private sector, and it's not necessarily going to be well thought out and kind of the correct way to do it for all the things that we've kind of been talking about. So in a sense, it drives the research at least in that way.
So my question is, what role do you think community advisory boards should play in genomics research, and what your experience has looked like with that? And if you have any advice for young researchers who are aspiring to get involved, how we can incorporate community-engaged research in genomics.
I can come into that. So I think community advisory boards have a huge role in research. And I should say, we're talking about the All of Us study that Julie was talking about, has a lot of community engagement and community advisory boards. And my personal experience is the first community advisory board I did was part of this BBC project, which it was just eye-opening. I mean, they were, this was a group of parents of children from the clinics that we were enrolling, and it was about 10 of them, and they they helped us. We engaged them in everything we did. So we started off in the beginning. This is what we're going to do. This is what the research plan. And the parts of it, they were like, that's not going to work. I mean, they made it very clear, and a lot of it had to do with trust. So things like if you draw blood from the baby before you randomize them, they're going to say, why did you draw my? I'm not going to trust you. You drew my blood from the baby, and you're not sequencing it. Like, why should I trust you? And so we changed it so we only took blood from the babies that were randomized to sequencing. And they, it was things like there's oftentimes not biologic parents. So in BabySeq 1, we had confirmed findings in the baby on the biologic parents. And they're saying to us, well, in these communities, they may not be any biologic parent. I mean, there may be one parent and not the other. Usually the father, may not be there, and the child's being raised by the mother and the grandmother. So we've kind of, had to kind of change how we were thinking about kind of the family testing. And then the other thing we've done is our community advisory board, we've given the opportunity to be involved in the papers we write. So we've written several papers, even our kind of marker paper about the whole process. We invite anybody who wanted to from the board to be part of that. And then they're also part of a paper we're writing about our interviews, because they help shape our interviews. And I think it's also, if you really, really want to think about community advisory boards, is getting them involved in what the purpose of the research is. What's going to be, what do they want to learn about? What do their communities want to work? And work with them as partners. And it was also interesting that some of them said to us that they'd been on other boards where they felt it was just kind of window dressing. And I think the way we've done this is there's no window dressing here. We're giving them work to do, and they're really helping us and being part of forming it. So if you really want to do community engagement, you can't just be like to be able to say we're doing community engagement. You have to do it in a way that's meaningful, that gives them the equal weight to the researchers, because you're studying their community. So that's kind of my views on it. And like I said, it really has been eye-opening and a really fabulous to be part of this group.
We have another question from the audience.
Good afternoon, everyone. My name is Marisol. I'm a community member. I have a question in regards to mandatory sequencing testing. If it was implemented, what considerations have been made in terms of how it would function in our health system, especially since our health system at the current moment, coverage depends if it's a pre-existing condition versus preventative care?
The logical answer would be that the Department of Public Health in that state would be the ones that are owning this data and owning this information, and that determines how it gets controlled and how it gets released. And there's other questions about, now, do we retest after a few years? We have all of this information. Do we go through the life course? So an example is, actually Rady Children's was able to partner with the state and have testing available for Medi-Cal patients, which is fantastic that we actually started there instead of private insurance leading the way. And it caused a huge problem, because children with Medi-Cal in the intensive care units of these hospitals that were participating were getting access to a test that the private insurance families didn't have access to, and that really helped to drive that change. And so the more that we can think about how we do this equitably, and mandatory is tough, especially with how much data there is, how personal it is, but it's doable. And if we make it mandatory or some version of mandatory, we're ensuring that everybody has access. And access is huge, but what does that access mean if you can't afford the follow-up testing, or you don't have access to the resources needed to do things? So there's an argument to be made that anything mandatory at that level right now might be unethical, because to give somebody information and not give them access to treatment is cruel. So
I'll just, can I say one thing? There is a law called Genetic Information Non-Discrimination Act. We call it GINA. I don't actually know how far it extends, but maybe she can tell us. But I do think we need more ethical discussion around expanding the law to protect against non-discrimination at insurance companies, but you can fill that in.
Yes, and that's exactly what I was going to say too. So GINA currently protects against health insurance and employers of companies with more than like 100 people, something like that, from discriminating against people because they have a genetic condition. So this kind of a pre-existing condition concept. The problem is that this went through Congress. Congress has been known to change their mind, right? I mean, you know, they probably aren't with this, but I think somehow the GINA, first of all, would have to be like a permanent thing and not be able to be changed if you're going to do this. The other issues, and that's what you're referring to, is that GINA only applies to health insurance and to employers. It does not apply to life insurance or disability insurance. Now, some states, my understanding Massachusetts is one, which is where I'm from, is one of them, do have laws that protect against discrimination for other type of insurance, but that's just kind of a state-by-state thing. So I think you have to set up that, you know, being illegal to discriminate about anybody in any way based on their genomic information if we're going to implement that. So add that to the list of things we need to change in terms of a public health perspective. It's a really great question.
I just kind of wanted to address this question we're dancing around a little bit in terms of GINA and legislation on genomics in the United States. People in other countries like to refer to the United States as kind of the Wild West of genomics and genetics in general. So I was wondering if each of you could kind of speak about some legislation that you would like to see in a perfect world in the United States on genetics and genomics, or if we even should go farther with our legislation or not. I'm really curious what would be most desired in a perfect world. Thanks.
Universal health care. Sorry, it fixes everything. If everybody has access to the medical services, doesn't have to worry about whether insurance is going to authorize something, then we can actually do something with genomics at a population scale, and that would be huge. And not to say that there aren't a million other things that would be fixed by this, but you asked about genomics, and that would really open the door to equitable and just use of genomics in healthcare.
Great idea, I concur. On top of that, non-discrimination in other contexts outside of healthcare could be expanded, like you mentioned, life insurance and disability, but employers also. I know GINA is supposed to protect you from employers saying, I don't want to hire you because you have risk of breast cancer or something, but expansion of that beyond just, I don't know, in making it more standard and wider than just healthcare would be helpful too. Yeah, that's all I got for now.
Yeah, this is a really small question, Celeste. Thank you for bringing it up. But I really love Dr. Chekichez and Dr. Non's answers. For me, when I think of the genome, it's this vast, mostly uncharted space. We have a lot more knowledge than we did 30 years ago. There's still so much about it we don't know, right? That information could be potentially powerful. I think we need better protections for how that information is used, but I also think we need better protections for how that information is interpreted, right? Sequencing is really cheap now. It's getting cheaper and cheaper. It's not, I wouldn't call it affordable, but it's certainly much cheaper than it was 30 years ago. But interpretation is expensive. What does this sequence do? What does this gene do? What does this variant do? What kind of clinical outcomes does it have? And what are the psychosocial outcomes for individuals and families who get a return of result of that particular variant, right? That has to be regulated. So I'd like to see a lot more regulation in this space, particularly around companies' ability to profit off of genetic information and genomic information of individuals. I think we need a lot more oversight and governance in that space to protect people, and we need more protections for individuals to be able to feel confident and secure participating in research and not have to think about whether, oh, my data is going to get breached, or is my data going to be released to or sold to a company for profit. Those kinds of protections really have to be there, so I'd like to see more of that.
Yeah, I don't really have anything to add. I just love Julie's answer. It's like universal health insurance, and clearly that's one of these other elephants in the room. I mean, if we had national insurance, we wouldn't have to worry about all these things. I think given that we don't, I think, to me, expanding, so GINA, it doesn't cover the military, and it doesn't cover companies that are like small companies, because I think they feel like they can't afford to. So it would be nice to get rid of those. I understand it a little bit with the military. They probably have reasons why you don't want, I kind of understand it, but I still feel like closing those gaps, making GINA permanent, and adding life insurance and disability insurance. So it's really any kind of insurance that people are getting that they would be covered.
Thank you all for coming and being part of a great discussion.